Is it the green button here? Okay, great. Well, we couldn't have two more different talks. I guess I like to stay close to data. And so, although I'm going to talk about constructs, I'm going to ground them in what data I have. The thing I was thinking about, Carla, when you were talking is we should probably do the measures that we think are important for our own treatment in each other's studies. So you think mentalization is important. So we in DBT should probably be using a mental, I mean, who knows what is, we stick to our own measures that seem to measure our own treatment. So anyway, DBT is a cognitive behavioral treatment that was originally developed for chronically suicidal people with borderline personality disorder. So most of you know this. I just want to emphasize a couple things here. When we say cognitive behavioral treatment, it is actually not like your typical cognitive behavior therapy. There are big differences, not just in terms of the things I'm going to talk about in a minute, but there are differences in terms of what is the focus of the treatment. The focus is really not cognitive. So we do not look at automatic thoughts. We do not look at core beliefs, and there really isn't as much of an emphasis on correcting cognitive distortions. It is, I always say, DBT is a small c, big B treatment. And so skills training is a huge component of DBT. And so there is a big emphasis on teaching behavioral skills. And this is not a group in the way that you think of a group. It's like a class. It really is a class where homework is given. Then with usually by a separate person, individual therapy is given, and that focuses on taking those skills that you learned in the class, in the group, and applying them in everyday life. And then we have phone coaching, which is an integral part of the treatment, and finally a consultation team, which can be very difficult if you're working out in a private practice as a solo practitioner. But it's really important because it helps, the way that I look at it is it really helps clinicians stay on track. If they have complex, because they're working with complex, difficult to treat disorders. So here are some of there are very few trials, studies that look at mechanisms of action of DBT. And so when Ken asked me to do this, I thought, okay, this will not be hard. I'll just go to the literature and pull up those studies. And we were doing a kind of a mechanism study, but it actually was surprisingly few studies. So this one study that came out in 2016 was done by Amanda Carson Wong, who was a former research coordinator of mine and is now at Rutgers. So I'm so happy to see her working in this. And so she looked at validation, levels of validation. In DBT, there are different levels of validation. And what she found is that the higher levels of validation, the more complicated, more particular, more specific type of validation is simply related to positive affect and a decrease in negative affect in the course of a session. So that doesn't exactly say how the treatment works, but these are actually the closest that I can get in terms of understanding mechanisms. Another study that came out of Linehan's group looked at basically therapeutic relationship and found that in DBT, perceived higher levels of therapist warmth, affirmation, love, and protection resulted in lower rates of non-suicidal self-injury. And then Marianne Goodman looked at, she did fMRI study before, and after DBT, and found that the DERS improved significantly, and I'll show you that in our data too. And then what she also found is improved amygdala habituation to repeated unpleasant pictures was associated with improved emotion regulation. And then finally, Winter et al. Did a really interesting study looking at distraction from negative rather than neutral stimuli, and found that there was a decrease in activity in the right inferior parietal lobe and supramarginal gyrus during distraction, and that this decrease was correlated with self-rated improvement. So that is basically, there is another study by Shelley McMain that kind of looked at mechanisms, but Shelley's right there, combined across the two groups. So I tried to just stick with the ones that looked at DBT. So I'm going to talk a little bit about some of the things that we found in our study as we are beginning to explore mechanisms. This is not so easy to do. I mean, the data is just a bear. And so this was just a 6-month trial of DBT versus SSRIs with clinical management. And so we wanted to do a 6-month trial, but we also wanted to look at outcomes. So we had a few outcomes. One was suicide attempts, one was suicide events, which just includes all of these additional kind of suicide-related behaviors. And so we found, so I'm just presenting this quickly, this is not what I really want to talk about, that suicide attempt was lower in the DBT group, and then suicide events also was lower, and NSSI episodes were also lower in DBT. And so we tried to find out, were SSRIs superior in any way? It helped in initial, more so in initial improvement in the CGI. So we looked at a bunch of things to try to understand what was happening in the course of the treatment, to try to really begin to get at mechanisms. And so when you think about mechanisms, I actually think about what changes in the patient. And another way, of course, to look at it, which I think is the way that Ken was thinking about it for this, is what are the changes, what are the active ingredients in the treatment that result in changes in the patient? And unfortunately, we don't have a lot of those measures in our study. So not surprisingly, DBT did better in terms of the working alliance from the position of the patient, and the therapist didn't differ in terms of the working alliance. So that's the only kind of like what's happening in the middle, with the relationship, what's happening in terms of the active ingredients. So that we have. So then we gave the Trier social stress test, and Eric Fertig is going to talk about this more tomorrow. And this is simply a social stress. So we wanted to see if this changed over time. And we looked at pre and post treatment DBT TSST results. One of the things that we found, interestingly, is that DBT resulted in a lower stress response, cortisol response after treatment. But when we tried to see what this was related to, was it related to any of our primary outcomes like suicide events, non-suicidal self-injury? There's nothing. So there is this kind of improvement happening in terms of response to stressors, but that is specific to DBT, but we couldn't tie to anything else. And so this is what it looks like. The DBT group, the area under the curve is like how high the cortisol response is. And so you could see that for the DBT group, the cortisol response was dampened. So something physiological is happening. And the same thing, this is just looking at a peak cortisol change, looking at it a little differently. So we still haven't finished exploring what this could possibly be related to, but it's a bit of a puzzle. So then we looked at some of our measures to try to see, okay, so if we think this is a behaviorally oriented treatment, are we getting behaviorally oriented changes? And in fact, we do. So impulsivity improved over time, in comparatively speaking, compared to medication. And then what we looked at was there a relationship between suicide events and the change in impulsivity? And so they were not related, but we did find a relationship between impulsivity and non-suicidal self-injury. So there is some sort of partial mediation going on that improvement in impulsivity is related to the decrease in non-suicidal self-injury. So impulsivity is one of the kind of the things that is changing in DBT. Difficulties and having an impact on the outcome that we were interested in. And then we looked at emotion regulation and found that, again, DBT did better. I won't go through what the differences were. And then we didn't find any difference with did it lead to improvements in suicide events. And I think this is because it's a trial of 80-some people, and there's not that many of suicide events. But when we looked at non-suicidal self-injury, again, there is this kind of improvement in emotion regulation seems to lead to a decrease in non-suicidal self-injury. So we have two things, and we actually had a lot of other measures. So it's not about hopelessness or depression improving, or hostility or anger. It's about these two things specifically. So the possible mechanisms of change for DBT seem to be improved stress response, decreased impulsivity, and increased emotion regulation. And so we still have a lot of data analysis to do for this because it's just a massive data set. We have fMRI data that we're looking at, and but these are some suggestions. And the only thing I would say is that I really loved the diagram that you put up, Carla, because I really think that that's kind of where we have to be going in looking at our treatments. But we are so far from there. And this is my research team, and that's the building that we sit in. Okay. Oops, sorry. Okay, so I think that that's about it. Thank you.